So yes, ECMO for fulminant myocarditis. Unfortunately, in that disease there are a couple of remaining questions. So yes, there are still lots of opening questions. The first question is how to set up the ECMO and when, for which patient. In fact, recent publications show that the timing is crucial, especially in this patient. So when the neutral dose is increasing, when you have a sliding slope, you should promptly start TMCS. Clearly, from my point of view, I think ECMO should be the first line TMCS because it gives you biventricular support. And with Impella, it's probably not enough because the myocarditis disease could start with LV and then move to the LV, and with Impella alone, it's not enough. So you need to have biventricular support, and ECMO is probably the most reliable way to get this biventricular support in a quickly manner. And then after starting TMCS, the main question is what about endomyocardial biopsy? Should I do it to prove the diagnosis? Should I do it to guide the therapy? But in fact, when you look at the recommendation says that you should do it. But in real practice, in fact, you have less than 30% of the patients who received endomyocardial biopsy. And there are a couple of explanations of that. The first one is probably it's because you have still risk to do that procedure on ECMO with a higher risk of tamponade, high risk of severe complication. Also that almost 80% of these patients will have a self-resolving disease, meaning that they will recover quite quickly in a couple of days with supportive treatment with ECMO. And also the sensitivity of EMB is far from being 100%. So I'm not convinced at all that EMB should be done for all patients, and this is something that we are working on with international retrospective studies, the Fulminant study, which is going to be published soon, hopefully.